Welcome, everyone. Thanks for coming to an Authors at Google talk featuring Thomas Goetz. Really excited to have you here. Thomas Goetz is executive editor at Wired magazine and has more than 15 years' experience in journalism, having worked at the Village Voice, the Wall Street Journal, and the Industry Standard. He frequently writes about science, health, and medicine, and he has a Master of Public Health degree from UC Berkeley. He's not a doctor, though, but given even that, he's written that things that kill us today aren't infections or epidemics, they are diseases of lifestyle. In other words, more than half of us are the agents of our own demise, which sounds kind of scary, but he's actually pretty optimistic about healthcare. He's here today to talk about the decision tree, and his main sort of argument is that the more people see themselves as decision makers in their own healthcare, the better their behavior and outcomes. And he also talks a lot about how technology can help people control their health better. So we have discounted books. So after the talk, if you'd like to go purchase one and speak to Mr. Goetz, he will gladly sign a copy for you as well. And then if you have any questions, we have a mic here after the talk. Please feel free to come up and ask. So with that, please welcome Thomas Goetz.
Thanks. So you guys don't have to stay so far back. If you come closer, it's easier for me, but your choice. So I'm very happy to be here at Google to talk about this. I actually, a lot of the ideas that are in the book were hashed out, some of them in this very room, when I would come to Sci-Fu over the last few years, which is a little conference that Google and Nature and O'Reilly put together. So it's fun to be here to talk about the same ideas again. What I wanted to talk about today was this idea of, there's been a lot of discussion, especially of late, about a healthcare crisis and a need for healthcare reform in the U.S. There's also, and that is true, and that's all it needs addressing, and we need to engage our government in providing coverage for people and making sure everyone has access to healthcare. But there's another issue involved, which is not so much a healthcare crisis as a health crisis, which is happening in the country. And that is one of, basically that, as Katie alluded to, we're making all sorts of decisions that lead to consequences that, that doesn't have to really work out that way. We're making poor decisions, poorly informed decisions that basically lead to a consequence of poor health. And I just want to explain that and discuss that a little bit today. So there's no end of health information, right? There's no end of access to information about our health. We are inundated with a cacophony of information, in fact. We are barraged with a stern list of things we should do and shouldn't do, mostly shouldn't do. And the trick is we don't actually do them. Only 3% of Americans manage to pull off 4 basic health behaviors that any one of you would probably be able to recite off if I put you to it. But they are to not smoke, maintain a healthy body weight, get some regular exercise, and don't drink too much. So only 3% of Americans manage to do all 4 of those behaviors consistently, which is pretty startling. What it means is that we're basically somehow disengaged from all that information that is coming at us. We don't really have a way to put it into an action. And what happens is that we are not only making poor decisions for ourselves, but we're making poor decisions for our families, and we are failing to act when we can, when we have these little moments of making choices. We're making the wrong choices. We think our health doesn't matter. Health too often is something that we decide we don't want to engage in, that is somehow a source of anxiety or fear for many people, for many Americans. For these people, that's probably the case, right? You don't want to think about it. I think that's unfortunate, and it's not the way it needs to be. What happens in practice, what's happening in this country, is that we're getting a series of decisions are cascading to more and more serious conditions. So you have what I call a cascade of comorbidities. You have one disease leading to the other disease, leading to the next disease. And this is the way most of us get sick and die in this country. In fact, 70% of Americans die of chronic disease. So these are diseases that these are not infectious diseases. These are not diseases that come out of the blue. They're diseases that slowly build, and it's the deterioration of health. Likewise, 70% of the money that we spend on healthcare in this country is spent on managing chronic diseases. So when you look at healthcare reform and where we should be directing some of the issues of reforming the cost side, well, this is part of the problem, right? Is that these chronic diseases are causing us to spend too much money to keep people alive when they've already had a disease beset themselves. It's not where we want to be. And of course, then you get this stat that was alluded to. 55% of Americans die of something that can be traced back to a personal decision. This was a study done by Ralph Keeney out of Duke University. He's an operations researcher, which is one of these fascinating disciplines. Maybe some of you are operations research. But what he did is he took the kind of standard CDC data, right? The mortality data that the CDC gathers on all of us. And he analyzed it in a slightly different way. What he wanted to do was to see how many of the mortality statistics could be attributed, if you work your way back, to a choice, when somebody had a choice. What he did was he excluded some of the things that we don't necessarily think of as a choice, such as getting in your car, right? Getting in your car, we pretty much have to do that if we want to be a functioning member of society. But getting in your car drunk or getting in your car and texting, well, that's a decision. So those decisions would be ones that would fall under this 55%. It's startling when you think about it that if more than half of us are dying because of these decisions, why are we making these decisions? Where do we lack this opportunity to engage? All right, so that's the problem, and that's the depressing part of the talk. What I want to do now is turn towards this idea, what I actually think is a very helpful and hopeful way of righting this wrong. Particularly, I want to talk about 3 experiments. These are 3 experiments that are in the book that I think are, to me, offer a new structure and a new approach to our engagement with our health. The first experiment takes place in London on Whitehall Street. In the 1960s, in 1967, a couple researchers from the London School of Hygiene came to Whitehall Street and decided that this was the place to conduct a unprecedented experiment. Whitehall Street is the epicenter of British government. It is the equivalent of, when you say Whitehall in the UK, it's the equivalent of saying Washington here. At the end is Big Ben, that's the halls of Parliament. Around the corner is 10 Downing Street, and up and down Whitehall Street are all the government offices, right? So the Labor Office, the Treasury, all the kind of offices of government. What's great, and what made Whitehall, especially in the 1960s, such an important place to do a population study, was that it was, as the researchers called, exquisitely stratified. So you had through the ranks of the civil service, through the ranks of the people who worked on Whitehall, you had 5 distinct categories. You had an executive class, an administrative class, a clerical class, executive, administrative, professional, clerical, and at the bottom was an other category. These were the messengers, the janitors, who kind of did all the work that was left for them. What the researchers found was that, let me back up, they specifically wanted to study the causes, not the causes of heart disease, but who was most likely to get heart disease. So that's why they were drawn to Whitehall Street, because they had this great stratification by class. So what they found was that the people at the bottom of the group, of the 18,000 people, the people at the bottom had 4 times the risk of dying of heart disease as the people at the top. So there was something really negative about being at the bottom, and there was something protective about being at the top. Well, we could all imagine what some of these things are, right? So they looked like the people at the bottom tended to smoke a little bit more. People at the bottom tended to not have as healthy a diet. They tended to be a little heavier. So those were known risks for heart disease, and so they factored all of those things out of the study. But they were still left with this profound relation between status and heart disease. The people at the bottom now, with all the factors excluded, all the known factors excluded, the people at the bottom are still twice as likely to die of heart disease as the people at the top. And there was no known reason for this association. So it was pretty stunning. They didn't know what to make of it. They thought at first that maybe there was something protective about being in the upper classes. Maybe there was some genetic inbreeding that maybe protected you if you were part of the aristocracy or the elite. That didn't hold water for very long. So what they were left with was the idea that maybe status in and of itself was the correlation. Maybe status was the driver towards good or bad health. They distilled it to this idea of control of destiny, that the people at the bottom had very little control of their destiny. When they made decisions, they were only somewhat likely to come true because they were subject to all the other decisions of everybody above them. While the people at the very top, they made a decision, and that was pretty much the way things went, right? They were in control. The people at the bottom had very little control. And we all know what this feels like. I mean, the people, we deal with these kind of ideas all the time. When we call customer service, those are people at the bottom, right? So when we call customer service and they can't help us with our cell phone plan, we say, can I speak to your supervisor? And they can't help us, so we say, can we speak to your supervisor? And we go up and up the chain until we get somebody who can make a decision, right? Somebody who has some control, somebody who has some authority. Likewise, we know what's it like to be at the other end of the spectrum. We know what it's like to have control. We know what it's like to be, we have all these phrases. When we're in the flow, we're in the top of our game, we're surfing the wave. This is a good feeling. We like to be in control. So the second experiment that I want to talk about takes place in the bathroom. Particularly, it takes place in 5,000 bathrooms around the country. There was this great research study that's ongoing out of Brown University. It's called the National Weight Control Registry. And what they've done is they've selected 5,000 people, 5,000 Americans who have successfully lost weight. They've lost at least 30 pounds and kept it off for at least a year. And so basically, if you want to study what are the secrets to losing weight, these are the people you want to talk to, right? So they asked them, they've surveyed them for all the tricks that they might have, all their behaviors, everything that they do. They've given them surveys after surveys. And what they found is a lot of the things that you might expect. They tend to exercise a little more than the average person, and they tend to watch what they eat a little better. So they have better nutritional choices. You might have heard that when you tend to eat a breakfast regularly, that actually correlates with maintaining a healthy body weight. That comes out of the National Weight Control Registry. But one of the other things they found that was quite surprising, that they didn't expect to find at all, was the simple fact that the people who successfully lost weight stepped on a scale a lot. In fact, 80% of them stepped on a scale at least once a day, and 80% of them stepped on a scale at least once a week, and 50% of them stepped on a scale once a day, like this woman, Jody Green, who every day steps on a scale, takes a picture of it, and posts it on Flickr. With a fancy pair of socks. What they've all realized is that this tracking, this idea of monitoring their progress, is a very powerful, helpful way to engage in successful behavior change. Now, it's known by the phrase in public health, they call it feedback, right? So when you get people involved in a feedback loop, when you help them monitor their progress, they tend to be able to successfully or have better success at changing their behavior. Now, you combine this feedback loop with the idea of groups, and you get even more potential for change. So this is the secret, in fact, of Weight Watchers, right? I don't know if when I started this project, I was actually very skeptical of Weight Watchers. What it turns out is that it's one of the few diet programs that actually works because they give you feedback. They have this point system that some of you may have heard of that basically translates the nutritional information box on the cereal and the food products into a formula that gives you a number of points that you're allowed, and that's a very simple way of getting people involved in this feedback loop. Likewise, they have these meetings, right? The Weight Watchers, they go to the meeting. They call it the magic of the meeting. And when you're able to share your information, when you're able to share your progress and track and compare your progress with other people's progress, it turns out to be an effective way to change behavior. So that's what we get out of the National Weight Control Registry. The third experiment that I wanted to offer today takes us to Kansas City, Missouri, and an orthodontic clinic. There was an orthodontic clinic a few years ago that, as many orthodontists do, they deal with teenagers, lots of adolescents who have braces. And what they had was a group of kind of incorrigibles who wouldn't brush their teeth. They had these kids who had just really bad oral hygiene. So they, in fact, they had the way you monitor this is you take photographs of your teeth and then you can analyze it for plaque coverage. So they had 40 kids who had about 70% of their tooth surface was covered with plaque, right? So 70% was the baseline. They split the 40 kids into two groups. One, they said, they brought them into the office and said, we'd like you to be part of this study with this new experimental toothpaste. So they gave them the toothpaste, said experimental in big black letters on the side, and they said, go home and brush your teeth. Like we've told you before, brush your teeth twice a day, 2 minutes a day. They even gave them a little kitchen timer to time it, and come back in 3 months. So that was the experimental group. The control group were 20 kids who were members of the clinic, but they didn't tell them they were going to be in the experiment. They had signed a kind of blanket waiver as a patient of the clinic, so they didn't have to tell them they were going to be in the experiment. They were just on track to come back in 3 months anyway. So after 3 months, you can imagine where this is going. After 3 months, the kids in the experimental group had profoundly improved dental hygiene. Still, it's not going to sound that profound, but their coverage had gone from 70% down to 50%, which was actually, after 3 months, was considered quite good progress. The control group, meanwhile, their hygiene had actually gotten a little worse. They had ticked up to nearly 80% coverage. So there was a real significant difference, right? At least 30% difference between the control group and the experimental group. The question is, what was in that toothpaste? What was the secret toothpaste that they gave? Well, it was Crest with fluoride, right? It was ordinary Crest. The magic wasn't in the toothpaste at all. It was in the fact that these kids were in an experiment, and they knew they were in an experiment. So no doubt some of you already know what this is called. This is called the Hawthorne effect. It's named after this kind of mythical study that was done in the 1920s by Western Electric Company. They wanted to see if they could get their workers to be more productive. So they would experiment with the lighting in the factory. They were making relays, and when they would raise the lights to see if they made more relays, or they would lower the lights to see if they would make more relays. Turned out when they did either one, lights went up, lights went down, they made more relays, because when the lights changed, the workers knew that the experiment was on. So this has become kind of the mythical way of describing this phenomenon, that when people are under observation, they tend to change their behavior. So it's related to the placebo effect. It's the same thing that you see Heisenberg uncertainty principle. These are kind of well-known phenomena throughout the sciences. They're particularly vexing with experiments that involved human subjects. So when you're doing clinical trials for drugs, for instance, the Hawthorne effect is this thing that researchers try to accommodate and try to kind of factor out. There are all sorts of ways of trying to get rid of the Hawthorne effect. What was really interesting about these orthodontists in Kansas City was they decided, what happens if we try to put the Hawthorne effect to work? What happens if we try to put it to work and engage people in the idea that they're in an experiment? And it turned out to work. So what do we do with this? What do we do with these three experiments? The idea of control of destiny from Whitehall, the idea of feedback and groups that we've gotten out of the National Weight Control Registry, and then this idea of making your life an experiment out of the orthodontic clinic in Kansas City. To me, it becomes, in essence, an algorithm, which being at Google, it makes sense to talk about. It's a formula that we can actually use to start being more active, more engaged, and monitoring our health, start taking some control of our health. If we can use the opportunity to monitor where we are, chart our progress, compare it to other people, actively use the data that we are generating all the time, every day in our lives and in our health, we can actually start to engage with that information and have some control, even though in the other senses of our lives we may not feel like we do have a great deal of control. It turns out that other research has borne this out as well. When you give patients an opportunity to participate in their care, when they're simply involved in the decision making, their averages, their outcomes on average tend to get much better. In fact, they tend to get about 20 to 25% better than people who aren't involved in the decision making. So it's also auspicious that I'm talking to you guys about this, because this idea of feedback in groups as powerful members or as powerful drivers of behavior change can be pretty much easily translated into the terms data and social networks, right? They're almost analogous terms. And the fact is that even though public health researchers have known for many years that feedback in groups are good ways of getting people to engage in behavior change, it hasn't been that easy, right? So you have to go through all these kind of fancy research studies, or you have to sign up with a program like Weight Watchers. There's a lot of friction involved in getting people to actually go through the process of feedback and behavior change. But if you translate it into data and social networks, if you start using information technology to tap in these same ideas, it becomes a lot easier. There's far less friction involved. It's far more easy for anybody to get access to these tools and strategies. This, to me, is what makes it so auspicious that we're at this moment in our healthcare system when we can start developing new tools and new strategies to work on these principles and start engaging people in their health. So one way that this looks, one way that this kind of comes to life is all the tracking apps that are on the iPhone. So this is my iPhone that I've loaded up with about 18 apps here. There are actually thousands of tracking apps on the iTunes store. I have my Nexus 1, and I'm going to suitably load that up with apps as well. But it's remarkable. There's the app at the scale there, Lose It. It's been downloaded 4.5 million times. And what it does is it's really nifty, very simple, free app that you enter your weight, and then you enter your target weight, and it calculates how many calories you should consume a day. Then every time you eat something, it gives you a menu of preloaded library of foods. And just a few clicks, you're able to register how many calories you're consuming, and it's constantly adding it and keeping you on track towards that overall calorie goal. Now, this is a much easier way. It has far less friction than the traditional way of getting people to write everything down, the food diaries that people traditionally have to do to engage in this stuff. Likewise, there's some awesome little calculators that are working our personal data into this kind of huge body of health research that's out there. When you think about the first slide I showed, that cacophony of information that we get, one reason that doesn't work is because it doesn't have relevance to us, right? It's all generic, impersonal data. If a study says that 50% of people are deficient in vitamin D, the question is, are you in the 50% that is deficient, or do you have enough? You want to know which side of the coin you're on. So there are these new predictive tools, these online calculators that are being developed. Very actually they're aggregating to cover more and more of our health, and they're remarkably effective at combining our personal information, our personal metrics, with this aggregate of generic information. So this is developed by a lab at Harvard University. It's called lifemath.net. And you basically just fill out a few little drop-down menus. So I did it here. And it gives you a specific list of actions that you can take, personal actions that you can take that will, according to general research, correlate to improved life. So it's integrating our own metrics, our own data, with what's known, what's generally told everybody, what everybody kind of hears. Take an aspirin. Cut down on alcohol. But all of a sudden, that information becomes very, very compelling and relevant to us in explicit terms. So there are all sorts of examples of this. The kind of, since I started writing the book 2 years ago, this was very scattershot. There were a few tools here or there. In fact, when I started work on the book, things like Microsoft Health Vault and Google Health didn't even exist, or they hadn't been announced yet. So in that time, in that span of 2 years, there have been dozens of tools that have emerged. Everything from 23andMe on one end that kind of gives us a look at our genetic information and how we can start building a baseline of our health based on our genetic predispositions, all the way to patients like me at the other end, which lets us build our personal data when we have a disease, from Parkinson's to a mood disorder, and share that information with other people and come to more insights and better engagement. And so I want to leave you with these three idea takeaways. The first is that data means more when it's our data. When we're given relevant information, it becomes incredibly more powerful driver of behavior change. It's demonstrated not just in the studies that I talked about here, but in dozens of other studies. And the second is that the more that we engage, the better our health. So this is the idea that I touched on, that when people are given a role in their health, when they're participants of their health, they tend to have better outcomes. Likewise, there was a study done of a meta-analysis of decision tools. So these are specific tools that when somebody is, say, diagnosed with a cancer and they want to know what chemotherapy they might be able to take, these are simple online calculators that help people understand the risks and benefits of every different chemotherapy, guiding them to what is hopefully an informed choice in correlation, in association with their doctor, of course. It turns out that this meta-analysis showed that, again, when people are given these decision tools, when they're given an opportunity to actually make decisions for their health and for their choices, even not just preventive decisions, but treatment decisions, care decisions, when you're faced with a disease and the really life or death stakes, the outcomes improve. And the third principle is as simple as this: every decision counts, right? So we're constantly making decisions about our health. From those little micro decisions about where to park and how far are we going to walk to work, to what are we going to eat, to whether we're going to go to the gym that day. Every decision that we make adds up to our health. We set off on these trajectories of health, basically. And too often, the approach is that it's kind of fate is taking us on our course, right? That our health is something that we are not necessarily in control of, or not necessarily even participating in. And I think that's exactly wrong, and that's what I'm hoping that people will start to realize, is that we all are the drivers of our own health trajectories. And that's the essence of what I'm getting at, because as far as I'm concerned, it seems like life is an experiment. None of us know at the end of the day, or at the beginning of the day, what the end of the day is going to hold, right? When we get up in the morning, we're never really sure. We might have a very clear agenda, but we're never really sure how things are going to play out on any given day or any given week or every given month. There are inputs and outputs that we're all in control of. We don't necessarily have a way to get perfect health, but we can help move the lever where we have some influence. We can help drive our way to better health. So that's the idea. That's some of the stuff that's in the book. I'd love to hear your questions. I hear that you guys are good and pretty versed in making people think on their toes, so I'd look forward to some questions. If you want to get in touch with me otherwise, this is how. Thanks very much. Somebody's got something. Do you have to use the microphone?
How did you tackle this topic? Because you said your background was is in journalism.
Right.
So what persuaded you to go into the medical industry?
So I come from a family of healthcare workers. So my father's a doctor, my mom's a nurse, my sister's a surgeon, my other sister was a public health worker. So I was the black sheep of the family as a journalist. I took the easy way out. So eventually I just, one of the cool things about working at Wired was that we are in the thick of it. We're not just covering things. We're really trying to engage in change. And I realized that in order to be better at my job, not as an editor, but as a writer, it seemed prudent and even a little bit fun to cross the bridge into Berkeley. So I worked out a way to go to Berkeley in the morning and work at Wired in the afternoon. And so this book basically came out of some of the studies I was doing at Berkeley.
So when you're looking at these tests, these feedback, 80% on the scale, people joining groups, how do you separate out the fact that those 80% are super motivated, that's why they're on the scale every day, versus being on the scale every day, cause versus effect?
Right. So so part of what you're getting at is to what extent do these strategies scale to broader populations, right? So so you get self-selecting in terms of the groups, but also the question is, if you're going to start asking people to track their health, how many people are actually going to do that, right? So it's there are certain groups of people who are more predisposed to engage in data, people who are more happy or comfortable with quantitative information. So that's all true, and in many ways this is kind of a classic early adopter phenomenon. what I mentioned was the idea of friction, right? So right now it takes a fair amount of work. Even the tools that I'm talking about, you have to actually work to find the tools. You have to work to use them. They're fairly easy to use, but you have to figure it out. It's, as I say, it's working out the classic kind of early adopter curve is that it's just getting easier. You have things like the Moore's law of sensor, which is making tracking movement much more passive and automatic, right? So you have little gizmos like the Fitbit that right now you can just, for $99, clip it on your waist, and you can track not only your cadence and your calorie count, but also your sleep quality. It's becoming easier and easier. So I look to things like high blood pressure and cholesterol, which 20, 30 years ago were not numbers that the general public was familiar with at all. In fact, cholesterol there was a lot of debate whether it even mattered for people. But now, large percentages of the population know their blood pressure, they know their cholesterol count, and they know which way they want to be driving those numbers. I think one interesting thing that might be relevant to you guys is that I just read this over the weekend. Americans are now reading 3 times as much text today than they did in 1980. That's not books. That's not magazines, unfortunately. It's just text. It's because of the internet, right? We're consuming much more information. And I feel that, to me, that's a very hopeful sign that we're becoming more comfortable as a nation with the idea of consuming information and working it into our lives and making choices based on it.
So beyond the book, what are you doing with this information? You're saying that as more people engage in their health, then it would improve. So is this kind of, is there anything being done in terms of trying to help improve the general populace?
So what am I personally doing? Well, that's a good question. I wrote the book. Hopefully people will read it. That's part of what I can do, right? I mean, as a writer, as an author, that's the way I communicate. But I'm also, there are programs like the Robert Wood Johnson Foundation, which has this really clever group called the Pioneer Portfolio, which is trying to identify a lot of the kind of trends in this book, or in what I was talking about today, and support those groups. So I'm a champion of them. I try to identify the kind of precursors of this stuff, and to me, it's a trend that one of the things that is fun about working at Wired and about writing in this way is that you're able to help people understand how technology is going to change their life. That's really what I think the mission of the magazine and the mission of the book is. That it's not just to write about a technology, but it's technology that is going to kind of really transform people's lives. And helping people understand that is what I can do, and it's what I'm hoping to do. So that's something.
So I actually thought your book was maybe on something slightly different, and I think it may cover this area as well, so I'll just go ahead and ask the question. So I think the things you talked about were in terms of keeping a healthy weight and not drinking too much and not smoking are fairly well established, and you can find consensus everywhere in the medical profession that those are things to be avoided. But as far as medical decisions or dietary decisions that are more marginal, there are things that are are a subject of debate. The typical way that has worked in the past is somebody has talked to a physician, and the physician has handed down a dictate or a mandate and said, this is what you should be doing and this is what you shouldn't be doing. And as I think everyone here is aware of, the availability of medical information online and directly to the individual has been increasing for the last 20 or 30 years. How have you seen this kind of these systems used to influence the sort of the well care that people have been doing for themselves for things that may or may not be as cut and dried as don't smoke. I mean, I know you mentioned taking aspirin on an earlier slide. That's a little bit less universally.
Right. Right. So, so the reason I chose to focus on things like obesity in this presentation is because it really underlines the disconnect between the way we deliver health information and what people actually do. Right. So there's there's this great paradox. Everybody knows what they're supposed to do, but we don't do it. And so that's the problem that is kind of besetting us in terms of our health. So what I'm trying to do in terms of this presentation is nip off a strategy for dealing with that. So that's why I was dealing with those things that are kind of truisms, but trying to change those truisms into something that you can actually effectively work on. Now, in terms of the other stuff that is less cut and dried, the book does talk about it. For instance, screening tests, right? So a screening test is a great idea and a great resource if it's a good test and if you are somebody who should be screened for that disease. So, for instance, something like prostate cancer. You may want to, when you hit 40, when you hit 50, men might want to get examined for a prostate cancer. Might want to get what's called a PSA test. The question is, what course of action should you take when you get those results? Because something like 50% of men over age 70 have some trace of prostate cancer. So that's a lot, but only 10% of men will actually die of prostate cancer. So the question is, how do you know what fraction you are part of, right? So do you want to go down this road of being treated for prostate cancer, which often boils down to radiation or removal, both of which carry potential side effects of impotence and incontinence. So serious life-changing side effects. Do you want to go down that road, even though you only probably have on a statistical level a small percentage of dying of that disease? That's a decision that everybody needs to make for themselves and negotiate those probabilities and statistics, right? So at every step of the way, do you get a PSA test to begin with? If you show up with a high level of PSA, do you want to get a biopsy? If you do get a biopsy, do you want to actually go radiation or removal? These are all percentages, right? There are statistics behind every one of these decisions. I mean, this is what a decision tree is. My hope is that by making it clear that there are always that all of these choices have a very clear numbers behind them and opportunities to parse the numbers actively, proactively, that individuals can better go down these courses and better understand what they're getting into. I think right now we look, as you say, we look to our doctors to kind of guide us, but the problem is that isn't the full bevy of information that's out there. There's by necessity they are a human filter, right? So we want to be getting all the information, but tailoring it to what our circumstances are. So again, that gets into the percentages of where do you fall. So to me, that's an example of how we need to be mindful of the fact that this is all probabilistic, that there are no sure things.
So as long as I'm up here, I'm going to follow up with one
Sure.
more, which is, so my experience has indicated that even people who are otherwise intelligent have a high probability of being innumerate, in that, when you present them with something like a statistical probability, even beyond just, the emotional impact of whatever is being talked about, death or, debilitation, they're just not able to understand the mathematics. They're not able to understand numbers. And what are the best things that are being done right now in terms of medical information to present those numbers in a way that is useful to the large percentage of people who don't really see them as useful as numbers?
Right. So one of the answers is stuff like those predictive tools, those decision tools that I mentioned, like that lifemath.net. So when you're able to process your information and make those statistics more specifically about you rather than about a generic average, that's one gesture. There are some specific things that people are doing. There's a wonderful project out of Dartmouth University. A couple researchers are trying to develop tools that make, for instance, drug facts much easier to understand. So following the footsteps of the nutritional information label, that kind of box, they're developing a drug facts box where all that kind of fine print of the side effects and the risks of a drug that none of us can ever understand, the drug facts box that they propose reduces that to very simple terms of who is this drug for, what are the potential risks, what are the potential side effects, and what are the odds that it's going to work for you. It's these very clearly stated, clearly presented information that help people understand exactly the pros and cons of a drug. And they've done studies that have shown that people are much more, when they're given that information in that form, they're much better able to parse the information. More broadly, there's some great work being done here at Google, among other places, in information design, right? We're actually, in my mind, we're entering this golden age of information design where we're understanding how to use graphical presentation of information to help people understand. There's a lot of, this goes to kind of the behavioral economics approach on this, is that people are irrational, right? And they can't understand numbers, and they tend to make bad decisions even when they're given the good information. I don't entirely buy that I agree that exists as a kind of status quo, but I don't buy that that's where we have to kind of, where things end. There are a lot of efforts, such as what's happening at Dartmouth, such as what's happening, there's this other researcher at Cornell called Valerie Reyna, and she's come up with this theory called the fuzzy trace theory. The idea is that, yes, when we give people just cold, hard numbers, and we ask them to just engage rationally, they tend to mess up. They tend to generally not understand the numbers. But when you give them a kind of fuzzy sense of what the numbers mean, she calls it the gist, when you give them the sense of the gist of the data, where they're able to kind of draw on their emotional, intuitive reasoning skills as well as their rational reasoning skills, they tend to make much better decisions. And so to me, that's incredibly hopeful, that kind of research, that, you know, it isn't this kind of cold duality between our emotional and rational selves, but actually that you can kind of use both of our sides of the brain and help people understand information. And I think that bodes great promise.
With this current generation, and I'm beyond the current generation, but so many people are involved in games, interactive things that are not only engaging but a lot of fun. And how important is fun going to be in involving people in their own healthcare decisions and changing their behavior? So
that's a great question, and some of the people that are doing some innovative stuff about this, like a local group called Hope Lab, they are trying to develop games, video games, that help people kind of make health decisions in a game format. Weight Watchers, for instance, this point system, a lot of people play it as a game, right? If you're kind of working the numbers and trying to stay under your points for a day, it becomes a game. And there's a lot of new research that's showing that when you are able to kind of have people play and work towards goals. I mean, that's one of the cool things about this data, right? It's your data, but you're able to move the numbers and move the targets and kind of play with it. So the Fitbit that I mentioned, you can go and read all the numbers and look at the graphs and your progress and stuff like that. But it also has this very easy, simple display of a flower, that the more you walk around, the more calories you burn, the taller the flower grows. It's a very simple reward mechanism that is playful. And I think those are really auspicious routes for helping people engage in that way. But we need more of it. I mean, we need more. There is a lot of cool stuff that could be done in that area. All right. Well, thank you very much. I appreciate all your time.